We will now discuss Sjögren's syndrome. Sjögren's syndrome is an idiopathic autoimmune disorder secondary to antibodies that predominantly attack your lacrimal and salivary glands. 90% of those affected are women. Sjögren's syndrome has been associated with rheumatoid arthritis, systemic lupus erythematosus, primary biliary cirrhosis, polymyositis, and patients with Hashimoto's thyroiditis. Sjögren's syndrome presents with dryness of the mouth and eyes. Patients will often say they feel like they have sand in their eyes. It's always burning and itching. This is called keratoconjunctivitis sicca. Dryness of the mouth also makes the patient feel like they have to constantly drink water. They have dysphagia, especially to dry foods. The loss of saliva from the attack of the antibodies also leads to rampant dental caries and loss of teeth. This is because the main function of saliva is to neutralize acid on the teeth and physically wash the food off the teeth and keep them protected. Some less common manifestations are vasculitis, lung disease, pancreatitis, and renal tubular acidosis. This one actually occurs in 20% of patients. When there's a loss of vaginal secretions, this can lead to dyspareunia, or pain during intercourse. Remember, lymphoma is the most dangerous complication of Sjögren's syndrome. The best initial test is the Schirmer test. This is when a piece of filter paper is placed against the eye, and then we observe it for the amount of tears produced by the amount of wetness on the filter paper. There's a threshold by which we can then say this patient may be at risk for Sjögren's syndrome. The most accurate test, however, is a lip or parotid gland biopsy. This is going to reveal lymphoid infiltration in the salivary glands. The best initial blood test to get is the SSA and SSB antibody. These are also called Rho and La and are present in about 65% of patients. These antibodies are also present in about 10 to 20% of patients with SLE. Some other abnormal findings are a positive ANA, a rheumatoid factor, anemia, leukopenia, and even eosinophilia. The best initial therapy is to water the mouth using frequent sips of water, sugar-free gum, and even fluoride treatments. We recommend eye drops such as artificial tears to avoid corneal ulcers. Pilocarpine and cevimeline are two medications that increase acetylcholine. These are the main stimulants to the production of saliva. You may not have heard of cevimeline, but it's a new drug that has a single indication of increasing the rate of saliva production. What you should know about this disease is there's no cure, but the lifespan is also not shortened. What you should also know is you must evaluate these patients for lymphoma because it can occur in up to 10% of patients. We're now going to discuss the vast topic of vasculitis. The cause of a vasculitis is unknown, but we do know it's some form of autoimmune phenomenon. The symptoms develop over weeks to months. They're gradual and progressive. All the vasculitides, including polyarteritis nodosa, Wegener's, Churg-Strauss, even giant cell, will give you a set of symptoms that are very common. These are fever, malaise and fatigue, weight loss, arthralgias and myalgias. So if they all present the same, how can you pick them out? Well, after we go through the next few slides, you're going to learn the clues and tricks to get these questions correct. Our first vasculitis is polyarteritis nodosa. It's a disease of the small and medium-sized arteries. It leads to a diffuse vasculitis that inexplicably spares the lungs. Chronic Hep B and C are highly associated with polyarteritis nodosa. Polyarteritis nodosa is very difficult to identify because there's no single pathognomonic feature. It can give you a glomerulonephritis, but you can't distinguish it from other types of nephritis without a biopsy. Remember, a UA is not enough to confirm that it's caused by PAN. In terms of the neurologic complications, any large peripheral nerve can be involved, but a neuropathy leading to foot drop in the peroneal nerve is the most common neurologic abnormality seen when polyarteritis nodosa is at fault. The last is a presentation that's very classic. A stroke in a young person is polyarteritis nodosa, so consider that as a possibility. PAN can cause abdominal pain that's worsened by eating. This is from the vasculitis affecting the mesenteric vessels. Because oxygen delivery is compromised, you get mucosal bleeding, as well as nausea and vomiting. When PAN also affects the skin, you can develop lower extremity ulcers, levator reticularis, purpuric nodules, and rarely gangrene can occur. What you must remember is that PAN always spares the lungs. This could clue you into the disease. Another presentation of PAN is mononeuritis multiplex. It's a confusing term. How can something be mono and multi at the same time? Well, let me explain. Mononeuritis multiplex is a multiple peripheral neuropathy of nerves large enough to have a name. For example, the radial nerve and peroneal nerve, or the ulnar nerve and the lateral femoral cutaneous nerve. The most accurate test to diagnose polyarteritis nodosa is a biopsy of a symptomatic site. Angiography of the renal, mesenteric, or hepatic artery can also show abnormal dilation or a beating pattern. Other abnormalities are anemia, leukocytosis, thrombocytopenia, or an elevated ESR and CRP. Some of us like to hang our hat on the P-ANCA as well, but keep in mind, a P-ANCA is present in only less than 20% of patients with polyarteritis nodosa. A urine analysis will show protein and red cells, but has nothing specific to indicate that it's PAN. Lastly, remember, you must test all patients who have PAN for Hep B and Hep C. Prednisone and cyclophosphamide are the mainstays of treatment for someone with polyarteritis nodosa. Therapy can result in remissions or cure in 90% of cases. For those who go into remission, approximately 60% will experience relapse in 5 years. You must also remember to treat the underlying hepatitis when found. Polymyalgia rheumatica, or PMR, occurs in those patients over the age of 50. It's associated with pain and stiffness in the shoulder and pelvic girdle muscles. Patients will complain of difficulty combing their hair and rising from a chair. They will have an elevated ESR and a normochromic normocytic anemia. Although there is muscle pain and there are no lab findings of muscle destruction, the CPK and aldolase are normal. PMR has a rapid, enormous response to steroids, and it works even at low doses. Giant cell arteritis, or temporal arteritis, seems to be on the spectrum with PMR. The difference is the presence of visual symptoms, jaw claudication, which is pain in the jaw when chewing, scalp tenderness, headache, and symptoms in other arteries, such as decreased arm pulses, bruits near the clavicles, or aortic regurgitation. In temporal arteritis, the ESR and CRP are going to be elevated, but this is a non-specific finding. Therefore, the most accurate test is a biopsy of the affected artery, such as the temporal artery. The treatment of choice is prednisone, but the question always comes up, biopsy first or treat first? The answer is, you start high-dose prednisone quickly. This is more important than waiting for the biopsy. This is because if you wait off on treatment, the patient can become blind. And what do we know about blindness? Blindness is irreversible. Therefore, if your clinical suspicion of temporal arteritis is high, start treatment with prednisone right away. Wegener's granulomatosis presents with sinusitis, otitis media, mastoiditis, and oral and gingival involvement. Wegener's can also be associated with skin, joint, and eye lesions. What's key for you is you want to look for a combination of upper and lower respiratory tract findings in association with renal insufficiency. If you see those three things together, click Wegener's. The best initial test is an anti-neutrophil cytoplasmic antibody. The most accurate test is a biopsy. Cytoplasmic antibodies are called C-ANCA. C-ANCA is the anti-proteinase 3 antibodies, and P-ANCA is the anti-myeloperoxidase antibodies. So remember, for Wegener's, get a C-ANCA. For Churg-Strauss and microscopic polyangiitis, get a P-ANCA. When asked about the best test for Wegener's, lung biopsy is better than renal biopsy, with sinus biopsy being the least accurate. But what if you're presented with all three? You choose lung biopsy. The treatment for Wegener's is prednisone and cyclophosphamide. Now here's a little tip for exam day. The clue to answering the most likely diagnosis question is unresolving pneumonia, not better with antibiotics. If you do not keep this in mind, you will not first think of Wegener's when presented with the case. Churg-Strauss is a pulmonary renal syndrome. It has asthma and eosinophilia. As with Wegener's and many other vasculitis, There can be fever, weight loss, joint pain, and skin findings, but these will not help you answer what is the most likely diagnosis. You must remember patients have asthma and eosinophilia as the clues for Churg-Strauss. Biopsy is the most accurate test. Treatment, that's right, you guessed it, is prednisone and cyclophosphamide. Henoch-Schönlein purpura is a vasculitis more frequently seen in children. HSP is characterized by 4 specific findings: in the GI tract with pain and bleeding, purpura on the skin, arthralgias at the joint sites, and hematuria. HSP is often a clinical diagnosis. However, if you must, a biopsy is the most accurate test. Serum IgA levels are always the wrong answer. They are unreliable when testing for HSP, so don't choose this as an answer choice. Now there's a little tip and buzzword when it comes to HSP. When the case describes leukocytoclastic vasculitis on biopsy, the answer is Henoch-Schönlein purpura. Leukoplastic reactions are painless, palpable purpura of the buttocks and legs, as seen here on the right. If they show you a picture like this, or they mention leukocytoclastic vasculitis, click HSP and move on. The great thing about HSP is most cases resolve spontaneously. Steroids are the answer when there are severe extrarenal manifestations associated with progressive renal insufficiency. But remember, steroids do not reverse renal insufficiency itself. Cryoglobulinemia is most commonly associated with chronic hep C infection. It is also found with endocarditis and other connective tissue disorders such as Sjögren's disease. But beware, don't confuse cryoglobulins with cold agglutinin disease. Here's why you can confuse them. They are both IgM antibodies, and neither disease responds to steroids. So if they're so alike, how can you tell the difference between cryoglobulins and cold agglutinin disease? Well, cryoglobulins are associated with hep C. Cold agglutinins are associated with EBV, mycoplasma, and lymphoma. Cryoglobulins present with joint pain, glomerulonephritis, purpuric skin lesions, and neuropathy. Cold agglutinins present with hemolysis. To treat cryoglobulinemia, you must give interferon, ribavirin, with boceprevir or telaprevir. For cold agglutinin disease, yes, that's right, stay warm. You can consider rituximab, cyclophosphamide, or cyclosporin. The lab test for cryoglobulinemia will show a positive rheumatoid factor and cold precipitate immune complexes. Keep in mind, steroids are not effective for this disease. The best way to treat it, as I mentioned on the last slide, treat the underlying cause, especially if it's hep C, with interferon, ribavirin, and boceprevir or telaprevir. Now here's a little tip. Despite the rarity of cryoglobulinemia in the real world, the USMLE loves cryoglobulinemia questions. Here's a little mnemonic for you to remember. SLE equals decreased C3, because SLE has 3 letters, so it's going to be C3. Hep C is decreased C4, because it has 4 letters. So remember, Hep C, C4, SLE, C3. The 2 most common questions the boards love to ask about Behçet's is what is the most likely diagnosis? Therefore, how does it present? And what is pathergy? I didn't say pathology, I said pathergy. Pathergy is when a sterile skin pustule occurs from minor trauma, such as a needle stick. For Behçet's, look for an Asian or Middle Eastern person with painful oral and genital ulcers with or without erythema. They may also have ocular lesions that lead to uveitis and blindness. They may complain of arthritis, and they even could have CNS lesions mimicking multiple sclerosis. To diagnose Behçet's, there's no characteristic lab abnormality. It's a clinical diagnosis. Patients, however, respond to steroids, but you must wean them off. You can't be on steroids for a lifetime. So you can actually use azathioprine, cyclophosphamide, colchicine, or thalidomide. We're going to be talking about the seronegative spondyloarthropathies. Try saying that 3 times fast. The 3 types of seronegative spondyloarthropathies are ankylosing spondylitis, psoriatic arthritis, and our favorite, reactive arthritis, also known as Reiter syndrome. These diseases commonly present in men less than the age of 40. They have involvement of the spine and other large joints. They have a negative rheumatoid factor. That's why we call them seronegative. They have enthesopathy, which is an inflammation where tendons and ligaments attach to the bones. They can have uveitis, and they can be associated with HLA-B27. Steroids aren't a good treatment for seronegative spondyloarthropathies, therefore do not get caught up in picking this as an answer choice. Despite the association with HLA-B27, this is never the best initial or most accurate test for seronegative spondyloarthropathies. It's just not sensitive or specific enough. A classical presentation of ankylosing spondylitis is a young man with lower back pain and stiffness. The back pain radiates to the buttocks. On exam, you notice flattening of the normal lumbar curvature and a decreased chest expansion. Eventually, the patient's spine will not expand in any direction, and enthesopathy can occur at the Achilles tendon. What's also very classical is look for back pain that's actually worsened by rest and relieved by activity. There are some other findings in ankylosing spondylitis that can help with your exam. There's a transient peripheral arthritis of the knees, hips, and shoulders. The patients can also have atrioventricular block or aortic insufficiency. Lastly, some will have a uveitis. The classic bamboo spine is actually a late finding. It's fusion of the vertebral joints. Here's an example of bamboo spine. As I mentioned, a very late finding in ankylosing spondylitis. The best initial test is an X-ray of the sacroiliac joint. The most accurate test is an MRI. The MRI actually detects abnormalities years before the X-ray can become abnormal. The ESR is actually elevated in 85% of patients. Again, non-specific, but it can help with the diagnosis. Here's another classical finding, narrowing of the sacroiliac joint seen in some patients with ankylosing spondylitis. Now here's a little tip. As I mentioned earlier, HLA-B27 is not a confirmatory diagnostic test. This is because 8% of the general population actually is positive for it. The initial treatment for someone with ankylosing spondylitis is an exercise program to increase mobility and NSAIDs. If the NSAIDs don't work, you can use an anti-TNF drug, such as infliximab or etanercept. 80% of patients will have psoriatic arthritis before psoriasis. It's actually very common when the psoriasis is very severe. Besides sacroiliac joint involvement, some other characteristic findings are sausage dizits from enthesopathy and nail pitting. Here's arthritis with nail pitting, accompanying about 10% of those with psoriasis. Although the ESR is elevated in almost all patients, it's nonspecific. The best initial test is an X-ray of the joint showing a pencil and cup deformity. There will also be bony erosions and irregular bone destruction. The uric acid level will be elevated from increased skin turnover. NSAIDs are the best initial therapy for psoriatic arthritis. Methotrexate is to be answered when a question describes severe disease or no response to NSAIDs. Anti-TNF agents are the answer when methotrexate doesn't control the disease, and steroids are always the wrong answer. So you can see the flow. NSAIDs to methotrexate, methotrexate to anti-TNF. We're going to start talking about reactive arthritis. Reactive arthritis can occur from three major causes. The first is secondary to inflammatory bowel disease. This is equal in men and women. From a sexually transmitted infection. This is far greater in men. And lastly, from a GI infection, such as a gastroenteritis from Yersinia, Salmonella, or Campylobacter. You want to look for a triad of joint pain, ocular findings, and genital abnormalities. Can't pee, can't see, can't climb a tree. The ocular findings can be uveitis or conjunctivitis, and the genital abnormalities can be urethritis or balanitis, which is an inflammation of the glands of the penis. Some patients will have keratoderma blennoragicum. It sounds worse than it is. It's a unique skin lesion that's reactive arthritis that looks like pustular psoriasis. Here's an example of the keratoderma blennoragicum. There is no specific test for reactive arthritis. What you want to do, however, is rule out the septic joint by tapping it. The diagnosis is mostly clinical, based on the triad previously described. You want to treat the underlying cause and use NSAIDs for the pain. Switch to sulfasalazine if the NSAIDs are not controlling it. Lastly, remember, antibiotics don't reverse reactive arthritis once the joint pain has started.